ahead.
I can't see, ma'am.
She is there.
She's there. Okay.
Yes.
Okay. So, good morning, all of you, on this fine Saturday morning. We are having a working day. Still, many have joined. First, I'd like to welcome all the faculties, staff from Jupiter Hospital. So also our beautiful, dynamic, learned lady, Dr. Lisa Balsara. I'd like again to welcome all of the delegates who have joined. So also the team from DG Shield. I welcome Mr. Deepan Mehta and Aditya, who is conducting this course. Myself, Dr. Rajan Sancheti, Resident Medical Officer at Lavale Pirangut of Bharti Hospital and Vice President to Indian Medical Association, Pune. First, I'd like to introduce our faculty, Dr. Lisa Balsara, who is pediatric hematologist and oncologist. A very rare to say and one of my favorite topic because I had worked in blood bank for about 18 years in Red Cross. Madam has completed her fellowship at MCGM, CTC, PHO, BMT Center at Mumbai. She specializes in thalassemia, various benign hematological disorders, pediatric oncology, diagnosis and treatment. She has handled oncological emergencies and autologous allogenic bone marrow transplant. We call it autologous bone marrow transplant. She works also at Avinash Cancer Clinic. Madam has participated in many national international conferences and has interest in clinical research. Many publications in national international forum, author of pediatric doses drug book. She has also co-authored patent publications under government. I narrate in nutshell, her specialization in leukemia, lymphoma, second pediatric solid tumor, neoblastoma, Wilms tumor, tissue sarcoma, brain tumor, Langerhans cells, histiocytosis. So also comprehensive thalassemia care. Now, I would say this is a very tough job because a lot of thalassemic, I would say I had in blood bank, and it was very difficult to give blood to all these patients. Next, nutritional anemia, iron deficiency anemia, spherocytosis, hemolytic anemia, benign blood disorders, platelet and coagulation disorders, immune dysregulation like HLH, ALPS, bone marrow transplant, autologous and allogenic. Then the main is cancer survivorship. This is a very important topic, I would say, difficult to, I would say, learn also, but she would explain in a very concise, short, comprehensive way, and definitely she will enlighten us in this, I would say, a very important field in pediatric thalassemia and all the cancer which are undergoing. So today's heading is Fight Like a Child, an overview of childhood cancer by Lisa Balsara ma'am. So I request madam to take the charge and enlighten us on this very important topic. Thank you all to join. Thank you, ma'am.
Thank
Please
you,
take
sir.
the charge.
Thank you, sir, for such a beautiful introduction. And before wasting any of the time, because today is a working day, I would like to start the seminar. I think we'll take the questions in the end, so all of us are in the same page. Aditya, are we good to go?
Yes, ma'am.
Is the screen visible?
Yeah, yes, it is
So
visible.
I'll start now.
Yes.
Fantastic. Please start.
Yeah. Good morning, sir. And good morning, the delegates. And thank you everyone for joining on a Saturday. I know how hectic it is today, but we'll have a quick overview. And today we are gonna start the topic "Fight Like a Child" because the child has the innocence and they do not worry about the treatment and the prognosis, and that's the best part because it gives the positivity. And with this slogan "Fight Like a Child," I would like to give you an overview of childhood cancer. So today's objectives for putting childhood cancer is an awareness about childhood cancer, an improved access to the healthcare all over the world, palliative care, which I don't like the word palliative, which I all usually use the word supportive care, cancer treatment to the affected children and adolescents, support to the children with cancer and their families. So when I was just passed out from my MD pediatrics and I wanted to pursue pediatric hemonc, my dad being a BE civil engineer, he asked me that क्या ही होगा? How will you earn money? बच्चों को थोड़ी cancer होता है. So I want to tell that one child is diagnosed every 3 minutes, 20 children every hour, 48 children every day, almost 3,000 children every week, 14,000 children every month, and around 2 lakh children every year. So it is not like it is very rare entity. We are diagnosing it every 3 minutes. It is there. And when a child is admitted with cancer, the whole family is affected with it. So what is the difference between the childhood cancer and adult cancer? Childhood cancers are mostly leukemia, lymphoma, neuroblastoma, Ewing sarcoma, retinoblastoma, Wilms tumor, sarcoma, and brain tumors. Whereas adult cancer, we see usually hear about breast, lung, oral, stomach, colon, and lymphomas. The difference between the main difference is childhood cancers are curable, most of them 90%. Why today we are talking about childhood cancer? Because it is currently the most treatable cause we have. Precision based diagnosis, better modality of treatment, better cure rates, better response, lesser side effects, and overall survivability is very, very good. Why all this is possible? Because there is increased number of specialists and cancer centers all over the world now. So what is my hurdle? Why I'm talking about it? Why I'm giving you an overview? Because the lack of awareness. There is an absolute lack of awareness and acceptance because we cannot accept that there is childhood cancer and we cannot accept that if it is there, it is going to be treated. And sometimes ignorance is not a bliss. So today we are going to learn about it. We need to create more awareness about it. The screening of the disease should be there. Diagnosis should be done by the specialist because sometimes when the peripheral centers do the bone marrow, there are certain tests which is not sent or which is not done, and the bone marrow examination on any such precision making diagnosis examination has to be repeated again at the center when they come for an oncological treatment. A proper treatment experience has to be examined, the monitoring of the response, and also we have to look that there is adherence to the treatment, which is very, very important. And we have to improve the quality of life by putting the nitty-gritty points, which we always do. So what are the early signs and symptoms of cancer? This is the most important slide. A pale child, tired, dull child, or having weakness, unexplained fever more than 99.5 from a very long time, which doesn't have any cause, a child having frequent and persistent infection, sweating and fever at the night, aches, pains of bones, joint, back, and leg. This all symptoms we already know. If there is an unexplained limb, bleeding, unusual swelling, if there is a white glow in the eye like this, there is weight loss and persistent crying. These are the symptoms which are explained in the textbook. But when you are in the OPD, the most important symptom is the mother's intuition. If the mother says, Madam, I do not think there is something right with my child, My child has never behaved like this. Please check my child. That is the first symptoms I will look after to go full haywire on all the tests. So what is the patient's journey? Basically, the symptoms are identified and set sought to a proper place. We make the diagnosis through the various tests. Sometimes it is only chemotherapy, sometimes it is a multimodality treatment like radiotherapy, surgery, chemotherapy, and then probably needing a transplant also. And based on this, there is survivorship. And if 1%, sometimes what happens is if the 90% cure rates are given, sometimes in those 10% who are very aggressive cancer, they relapse after treatments and we have to find the other modalities. How do we make the diagnosis? First, to the blood investigation, complete blood count. We always look at the peripheral smear because the answer lies in peripheral smear. The serum ferritin, LDH, LFT, RFTs, and we also take the help of radiological examinations like X-ray for mediastinal mass, USG for liver and spleen, X-ray long bones, PET scan. Bone marrow examination for blood cancers. We look after the morphology, IHC flow cytometry, stress cytogenetics, and sometimes we also do the gene sequencing. So cancer diagnosis, as we all know, these are the various multimodalities which we go through based on the what type of cancer and what type of symptoms are there. Now I would like to present the interesting cases which we have seen in our OPD, which were not usual. My first guess was not cancer in all these cases, and we had a CID-like workup in all these cases. So I had a 2-year-old female child present with similar complaints like limping and excessive crying since 1 week. There was an on and off fever since 45 days, and there were no bleeding tendencies, which is petechiae purpura or a nasal bleeding. So we did a CBC here and we found the HB of 7.2, WBC of 4,500, and polymorphs of 45, lymphocytes of 42, and platelets of 1.76. Overall, looking like some anemia, not showing any similarity to malignancy or any benign conditions, and a 2-year-old child. So what we did, because she came with limping, we did a bone scan and we found multifocal areas of osteoblastic activity involving the long bones. And as the CBC suggested, and as the bone scan is also suggesting that please do hemolytic anemia, we did, and everything came negative. But then I went back to the peripheral smear, which I found blast. And then it showed 45% of blast, and we did not wait. We did the bone marrow. It was B cell leukemia. Case number 2, there is 2 years, 8 months child and fever since 20 days. It's a high grade fever. I did a CBC and I found HB of 7.3, 8,500 and 2.45. But what I found was that there was some cracks. We did a chest x-ray and we found something suspicious. So we did a CT. And we found a thick-walled abscess, 2.7, 3.8, 4.1 centimeter. And there was lymphadenopathy. And peripheral smear, when we back, it was 12% blast. So CBC was not showing anything, but yes, peripheral smear gave answers all the time. And the CT picture, if I want to show, this is the CT picture with a thick-walled abscess in a 2-year, 8-month child. And it is almost like a tennis ball in her chest. And then we did a bone marrow. It was 84% blast, suggestive of acute myeloid leukemia. She's currently doing very well. She's on maintenance therapy. Now, I don't want to tell that every child is cancer, every hematological condition is a malignancy. There was an 18-month-old child referred to us for recurrent episodes of high-grade fever and pancytopenia. This child was referred, please do bone marrow. This was the only referral note we get. And this is the blood picture starting from 14th of October to 12th of March. This slide is not made by me. It is made by the parent. And you can see there is a serial HB drop from 9.3 to 6.2. The counts were okay, but what the lymphocytes were suggesting was on the higher side, which he was referred as leukemia, which is showing that I should do a bone marrow. But I felt something wrong with the neutrophils. What I felt was neutrophils were too low. It was going 17, 21, this thing. So we waited and we saw the serial peripheral smear and peripheral smear showed no atypical cells throughout. And so what we did is we waited till the HB dropped to the level where it showed pancytopenia pictures and where the need of bone marrow was suggestive. And we also did a bone marrow showing hypocellular marrow with normal megakaryocytes. But what I found was the child was limping a bit. So I did the long bone x-rays, and what we found was there is a cortical thickening on all the long bones. So there is anemia, pancytopenia kind of picture with neutropenia and cortical dysplasia. So I did an NGS and we found it was TBXAS1 gene mutation. This is known as glossal hematodiaphyseal dysplasia. There are only 15 cases reported till there, only 6 in pediatric age group. Treatment is steroid. It is a corticosteroid responsive anemia. So this was the latest article which we found. The child is doing very well, maintaining HbO 14.3, growing well, and he's absolutely fine on steroids. We're tapering steroids. So every case referred is not leukemia, but we keep that as a differential diagnosis always, that there is a bone marrow involvement in all the cases. So we have a lot of options for treating cancer, starting from chemotherapy till hormone therapy, radiation therapy, immunotherapy, targeted therapy, and even bone marrow transplant. When the cancer is very aggressive and relapsed in a very, very short period of time, we keep this option open, and this is talked in the first counseling itself, that there is a chance your child will need it. So talking about the survival rates, if we look at the survival rates from 1960 till 2000, it is a good survival rate, almost reaching 95% in ALL, NHL, Wilms, and a lot of other cases also. Why? Because the child fights like a warrior without thinking about how much cost, how much, what is the prognosis, what is going to happen. It is almost like a 2.5 years treatment for leukemia, and then do they well. Why does it happen? We do not know, but a healthy lifestyle and a physical active lifestyle helps us for the prevention of cancer. It is definitely sure. So these photographs were taken after the parents' consent, and I wanted to show how beautifully they fight. This is our youngest warrior. He was a HLH case, and now he's doing well. He was our AML case, now doing well. He required transplant. And these are all our acute leukemia cases. This is a daycare where they're playing when they come for the chemo infusion. So the basic question they ask is कि कैंसर के बाद जिंदगी कैसी होगी, मैडम बाल वापस आ जाएंगे क्या? So certain cancers and certain treatments are very rewarding. So this was the child admitted to us with B-cell leukemia. This was the time when he was taking treatment with us. And then he came to us in the follow-up, and currently he looks this handsome. And he's the same child. And he's doing very, very well in life also. He's studying and all. So there is always the light at the end of the tunnel. No matter what you're going through, there is light at the end of the tunnel. It may seem hard to get it to, but you can do it. Just keep working towards it, and you will find positive sides of everything. And childhood cancers are increasing day by day, but the cure rates are also improving day by day. With that, this is the tree of faith, which we use for faith, hope, and love for treating childhood cancer. And with this, I will like to end the session.
Thank you, madam, for a very lucid and I would say short but sweet presentation on Fight Like a Child.
Yes.
And we have talked a lot about two things. You
Yes, sir.
talked about gene mutation,
Yes, sir.
glossal hematodiaphyseal dysplasia,
Yes, yeah. Yes,
right?
sir.
So
Yeah.
is it that we just take a blood sample and
Yes,
we
sir.
can detect cancer?
Sir,
from the
most of the
genetic study?
blood cancers are, if it is a solid tumor cancer, we need to take the biopsy. If it is a blood cancer, we do the bone marrow. But for
Okay.
gene sequencing, we only send one EDTA sample, and that is the only test. The results come between 10 to 4 weeks of time based on the test required, and then the mutation is held over.
Yeah, correct.
Yeah.
So I think this is a very simple way.
Yes,
And
sir.
you talked about PET scan and other things.
Yes, sir.
So I think that is a diagnosis. Only PET
Yeah.
scan is sufficient, or actually you said about CBC, but is it 100% that from CBC we come to know and we can treat all the pediatric patients? Because a lot of issues are there in pediatric, and
Yes, sir.
referral also. General
Yes, sir.
practitioners are known to have some good awareness.
Correct, sir.
So what happens when we find that the patient is thalassemic? We say
Mhm.
send to blood bank. Have a lot of
Mhm.
issues there in blood bank,
Correct.
because I worked there maybe 10 years back,
Yes,
and
sir.
it was very difficult for us to procure birth for these helpless families, and the
Yes, sir.
father and mother were always concerned.
Correct.
So this is, I would say, the best option for
Mm.
bone marrow transplant. At
Yeah.
that time, I think there was a huge amount for bone marrow transplant, and the father, mother, they were, I would say, really worried what to do. We tried
Yes.
to explain. Now that
Yes.
there's, as you said, there's a light at the end of tunnel. So
Correct.
I think you are the person, right person that we are talking to. The
Yes.
light goes towards you, that you
Yes.
bring the smile on those family faces.
Yes.
So just I have seen the photo of some patients.
Yes, sir.
They are concerned about the bal, that is ears.
Yes. Yes.
So I
Yes.
would say bal bache, bal bache usse.
Yes. Yes.
So
Yeah.
everything can be fit and fine after
Yes.
you have some good consultant to look after,
Correct.
and
Correct.
this is the right, I would say, person or
Yes, sir.
faculty who can deal with your patients. And
Yes, sir.
we should create a lot of awareness in
Yes.
public also
Yes, sir.
about this thing, marriage counseling and this thing, so
Yes.
that we won't have much of thalassemia people. This is
Correct.
what we used to decide.
Yes.
Still, we have not achieved. But I think we should have an end. Just we are having end of tuberculosis. So I would
Correct.
say end of thalassemia patients, at least
Yes,
on
sir.
in India, or maybe some part of whether we can intervene other patients also.
Correct, sir.
So two three things I wanted to know
Yes, sir.
about. Uh, Now that I think participants have to be more, so can we have some good sessions with the Indian Medical Association also? I
Sir,
request Nitin.
anytime. Sir, anytime. Because
Uh,
there are a lot of things, sir. Because earlier it was like bone marrow transplant was not affordable. But currently,
yeah.
sir, what bone marrow, like in Jupiter, we have completed 27 and 12 pediatric cases. And in that, sir, sometimes we understand that the parents cannot pay a lump sum amount of 10 lakhs or 12 lakhs. Everybody cannot pay that. So
Right.
how we are trying to help, or how we are making it affordable, because treatment should be affordable also. If you're going
Yeah.
to Mars and if it is not affordable, then it is of no use. So we have
Correct.
tied up with a lot of institutes like PM Fund, CM Fund, SIPLA, Kalpataru. And sometimes, sir, it is so wonderful that through the digital marketing, like crowdfunding of Impact Guru or Keto or something like that, parents have raised around 25 lakhs in 8 days through digital
My
marketing and
God.
through all this. And sometimes it once happened with us, sir, that one child raised 25 lakhs and he took the permission of all the authorities involved from the hospital and from the digital marketing website. And he gave half of the money to the adjacent bed person who was also requiring money for transplant. And within that, around 8 to 10 days funded money, we were able to do 2 transplants at the same time. So
Great.
money sometimes is not an issue. We have also, just started the transplant because after getting all the help, and sometimes we have got all the money within 7 days, and maximum money which time required to raise the money for all this transplant, because of all these NGOs stepping in and a very robust social marketing department and everything, the maximum time required was not more than 3 weeks, sir. So we save a lot of time and a lot of because the early prognosis, the better prognosis is due to early treatment and early diagnosis. So that has to be a very aggressive approach for everything.
Yeah. Hats off
Yeah.
to all of you and the marketing team of digital people
Yes,
and
yes,
the
sir.
NGOs and
Yes,
whoever have come for this humanitarian cause, I would say. It is
exactly.
wonderful. As you said that 50% was shared with other bed. This
Yes,
is, I would say, a miracle. No
yes,
one does
yes.
that. I
Yeah,
would say it is a really good gesture
yes,
from that patient who has done it.
correct, correct.
And I think this is an example or an inspiration to all of doctors also and
Yes, sir.
all of the patients.
Yeah,
So I think this might be on this thing, what to say, YouTube also. So this
yes, sir.
can be example from your side, and we can
Yes,
have such awareness programs.
definitely,
Because now being
definitely,
a
sir.
working day, we won't disturb you much. You have, I mean, a line of patients sitting, and you have to
Yes,
look after the OPD also. Thanks a lot. We'll be in touch, and thanks
definitely,
all the
sir.
team.
Mm. Thank you so much, sir, for the
Perfect.
opportunity.
Okay. Chalo, good day, ma'am. Thanks
Good
all
day,
of
sir.
you. Thanks all the
Thank you.
delegates to join. Good day. Bye.
Thank you, sir. Thank you.